Good afternoon, everyone. I'm very pleased to be here today. It's my first visit to Duke. I feel this is a great place. Everybody is talking about global health issues. You have a very good global perspective of in this campus. I really feel at home in this here. I'm going to share some of my recent research on a discrete choice experiment in the area of attraction and retention of health workers in rural China. My presentation will start with a brief introduction of the imbalance of health worker distribution between urban and rural areas, and then introduction on the discrete choice experiment as a method to be used in this area, followed by method results, and finally some implications for future research and policy making. As we all know, health workers are not equally distributed according to the health needs of population in rural and urban areas. WHO has an estimate that there are about 75% of total health professionals working in the urban area to serve a smaller urban population, while there are only 25% of them serving a larger rural population. So medical graduates, when they graduate from the university, they tend to find a job in the urban city. And the existing health workforce in the rural area, whenever they find the opportunity, they would love to move from the rural facility to the urban facility. So this is not only in the developing countries, but also in some developed countries we will observe the same situation. So there are many reasons behind the preference of health workers in urban to rural area. Among them, there are income disparity between rural and urban, whether they can recognized by the local society, whether they will have training opportunity in the health facility, the living condition there, and also opportunity for further career development. So in many countries, the government have implemented different interventions trying to attract and retain the health workers to work in rural area. In 3 years ago, 2010, WHO issued an important report summarizing these different interventions. They categorized this into 4 different groups. The first type of intervention is called educational intervention. For example, medical university can recruit students with rural background, or they set up universities in the rural area rather than in the urban city, or in the curriculum they can set up some rural-related courses. So all these are believed to be able to attract them to work in the rural area after graduation. The second type is called regulatory interventions. Excuse me. Also called compulsory intervention. So medical graduates are obliged to work in the rural health facility based on the contract they sign with the local government or local health facilities. The third type is called financial incentives. This is easy to understand. Give you more money to attract you to work in a certain area, certain facility. Finally, is some non-financial incentives, which include some personal or professional support. So the WHO report gave some recommendations on the strength of the evidence. Some are with strong evidence, some with weak evidence in this area, in the very different interventions. So, but although we have many different interventions, but the evidence so far is a mixed picture. The same intervention may work well with good evidence in one country context, but if you implement the same intervention in another country context, it may show no effect at all because of the different context issues. 2 examples. One is the targeted admission policy, which is to recruit students with rural background. This single intervention is believed to be the most strong evidence. There's one Cochrane review said this is the single factor most strongly associated with rural practice. This is the one, I think, in many countries, like in Japan, there's a GT Medical University. They have been recruited 2 to 3 medical students with rural background from each prefecture since 1970s, which is believed to be a very successful program using this policy. Another frequently used intervention is the financial incentives. This is widely used, but the literature we can say only few of them are rigorously evaluated. With those evaluated intervention, it gives mixed results. I read one systematic review on the financial incentive, the impact on the attraction retention. There are, I can't remember the number, there are 2 studies shows positive results, there are 9 shows negative, and another 4 or 5 shows no result at all. So it's a mixed picture. There are some literature in this country, in the USA, called the loan repayment scheme. So the students have a heavy loan after graduation. The government can help them to repay the loan, but as a condition, you have to work in the rural area for a certain number of years. So it shows this country shows some positive results of the loan repayment scheme. But this may not be applicable to China because student loan is not popular in China, so the same intervention may not work in other countries. Let's turn our attention to China. This is the number of health professionals in China since the establishment of the current government to now. We can see the increasing trend of total health workers, including both nurses and doctors, in the last 60 years. Especially after the year of 2000, there's a sharp increase. We believe the reason of that is the expansion of the medical universities around the year of 2000. There was a rapid expansion of student admission in the medical universities. There's another point I want to make here is the doctor-nurse ratio in China. We have less nurses than doctors, which is unique, very unique in the Chinese situation. But in the recent years, you can see the blue line is the number of nurses. We have a little bit more nurses. Currently, the ratio is about 1 to 1, 1 doctor to 1 nurse. The reason I have talked to Dr. Xie this morning, the reason for that is doctor and nurse, they are paid a similar salary in China, so you don't have an incentive to recruit more nurses to have better efficient use of your budget. So they have similar, and doctors can do a better job than nurses, of course, sometimes. So that's one of the reasons. So as a result, many doctors in China are doing a nurse's job. Part of their job is a nurse's job. So this is, but in the Ministry of Health has a 20-year planning for human resources. In the long-term plan, we are going to have train more nurses in the future. Compared to our neighbor countries and some BRICS countries, China is doing fine in terms of number of doctors per 1,000 population. We have less number of doctors than Japan, but better than India, Philippines, South Africa, Thailand, Vietnam. So in terms of the amount of health professionals, China is fine. WHO has several years ago, they gave an estimation of the need for doctors. There are 57 countries in severe shortage of health workers. China is luckily not in that list, so we are fine in terms of numbers. But there are 2 big problems in terms of the human resource for health in China. One is the distribution of health professionals between rural and urban. Here we can say in urban cities, it has 3 times in terms of number of health doctors than in the rural area, 3 times. So the nurses, the gap is larger than the doctors. So I said the first thing is the maldistribution of health workers between rural and urban. But in addition to that, to make it even worse, the quality of the existing health workers is not even in rural and urban. You can see here, this is primary healthcare providers. So in the rural area, there are only 13% of them have a university degree, which means they have a 5 years education. After high school, they have 5 years education. The majority of them, 87% of them, have only 3 years education, medical education after high school. So you can imagine what kind of service quality they can provide in the rural areas. In the urban cities, better. The primary healthcare system have about 43% of them have a university degree. So the two things make together, rural area has less number of doctors with lower quality in terms of medical education, which makes the situation in China is the rural population cannot have equal access to qualified health services as well as in the urban cities. Another 2 points I want to make here is the rural doctors in China have low income. Most of them have about $300 to $400 US per month, which is barely enough for them to make a daily living. So there's a big gap between the rural and urban health workers. There's another fact that there is a potential health workforce in the urban cities, surplus of health workforce in the urban cities. There are many medical graduates who do not want to work in the rural area, but they cannot find a job in the hospitals in the urban cities. So they choose to not work in the health sector. They either self-employed or work in a commercial company, pharmaceutical company. There was a report last year. Every year we have 600,000 medical graduates, but only 1/6 of them finally become doctors. So whether this statistic is correct or not, there's a great waste of education resources. So there are potential policies we can try to make real changes to attract this special group of people to work in the area, in the rural areas. So this is the background of the human resource for health in China. Next, I want to briefly introduce the methods we use in this study called Discrete Choice Experiment. DCE is mostly used in the marketing area, so to predict the preference of customers on the certain goods or services. Each goods and services, they have a special characteristics like price, utilities, like this. So the choice of each goods or service are determined by these attributes. DCE is, in the recent years, gradually used in health service research. People use it, researchers use it to predict the demand for different health insurance plans. Patients demand for different pharmaceutical products or different health services. There are few studies in both developed and developing countries to use in the human resource area to show the attraction and retention of health workers in remote areas or rural areas. Although we call DCE as an experiment, but indeed it's not a real experiment. It's a survey-based study. So we give the respondents choices of jobs, make them to choose. But what this method can measure is their, we call it stated preference, is what they say they will do, not their real choices, not the revealed preference. Let's look at an example. If we look at the mode of transport to work, there might be two options. One is by car, the other is by train. These are the two alternatives. So each alternative has several attributes in terms of the duration of transport, the time used to walk to and from to the station, or the price. So this is the attribute. Each attribute have 2 or more levels. For example, the price, you can set the price at $10 or $5 or $4. So the respondents are asked to choose either car or train. This is the typical DCE question. So by choosing either choice, there are 2 important assumptions. One is any choice you choose will bring you the maximum utility. And this maximum utility is determined by the attributes and levels. So this is the assumption behind the DCE. So the methods we use in this study is DCE, but I will talk about the procedures we used. So we did a pilot study first, using literature review and in-depth interview with a few township health center directors, some doctors, and some nurses. The content of the in-depth interview is to let them talk what factor will influence them to choose to work in a rural area or to choose to remain to work in the area. So based on this study, we decide as a group these following 6 factors are the most important ones in deciding their choice. So number 1 is the working location, whether it's in a rural area or in an urban city. Now we take the township as the rural, county as more urban environment. Their monthly income is 2,000 yuan, 4,000 yuan, 6,000 yuan, 8,000 yuan. Here, as I said before, the current level of income, monthly income, is about 2,000 yuan, the first choice. But we would like to see if we increase the monthly income, what's the potential impact on their job choices. So we set up some currently existing income level. Yeah, so it's unrealistic. This is actually one of the advantages of DCE. You can set up some kind of non-existing but have potential policy implication in the future to see the impact. The third one is the permanent post, whether this post is a permanent or non-permanent. Training opportunity, we define training as whether you have a training opportunity for at least 3 months within every year, every 2 years. If you have this opportunity, we call it yes, otherwise no. Whether you have a good education opportunity for your children, and whether you have a promotion opportunity after 5 years or 3 years of work. So this is the 6 factors we believe are the most important ones. So we choose these 6. This is the attributes and these are the levels to design the DCE questionnaire. So we need to create some hypothetical job choices for the respondent to choose. So here we have 6 factors, 5 of them with 2 levels, 1 of them with 4 levels. If we use a 4-factorial design, we have 128 different combinations. Of course, we cannot do that. A doctor will spend a week to answer the questions. So what we did is to use an orthogonal design technique to select a small number of questions, 16 hypothetical job choices. This is as the job A for them to choose. I don't want to go into the detail of this technique, but we need to make a job B a pair of job choices. So that 16 is job A. We need to make a match for them to choose. So we use a technique called foot over or shifting design to make 16 pairs of choice. The technique is it's called mirror image. So if job A is in rural area, then job B is in the urban. Job A is with permanent post, job B is without permanent post. For the attribute with 4 levels, so if job A is 2,000 yuan, job B is 4,000, and so on. So this is the match to make 16 pairs of choices. This is the actual example we use in the design. So job A and job B with different level of attributes, and the respondent asked, would you choose A or B? So very briefly, this design will make sure that the 6 different attributes are mutually independent. There's no collinearity between them. While if you do this in a cross-sectional survey, these 6 factors are heavily we have heavily multicollinearity between these 6 factors. Level balance means in job A and job B, each level of attributes appear the same number of times. Minimum overlap, because of the shifting design, there's no level in each attribute are the same in each job choices. So this is the so now we have 16 pairs of choices. Now we consider that this is still very time consuming for the doctor to answer the 16 questions. So we divide them into 2 parts, part A and part B, each part with only 8 questions. So they only need to answer these 8 questions to save their time and also to improve the quality of the survey data. But we also think that some doctor may not understand the DCE question correctly or carefully. So we add one additional question, consistent check question. In this pair of questions, so the levels in job A is apparently better than the levels in job B. If the doctor or nurse fail to choose the so-called correct answer, we consider this as an invalid response. We will exclude this from the final data analysis. Study settings. We did this research in 3 provinces of China: Shandong in the eastern coastal area, Anhui in the central part, and Shanxi in the west part. In each province, we select 3 provinces to represent their socio-economic development status, 5 townships in each county. So we visit each township health centers. All available doctors and nurses were asked to fill in the questionnaire. In total, we have 222 doctors, 165 nurses who submit valid response questionnaires. So this is the sample size we use for the data analysis. Very briefly to show indicated by the red star, these are the 3 provinces we use in this survey. Data collection. The questionnaire is self-administered because while choosing job A or job B, you need a lot of mental work to do inside. So we don't want to interrupt them. But we have our master student at present to provide any assistance when needed, but also to monitor their filling the question to improve the quality, to make sure they are not carelessly filling the questionnaires. This is only done in August this year, so this following I will present some initial results. Data analysis, we use conditional logic model. So the logic probability of choosing either A or job B is a combination of is a linear combination of the different job attributes, with error term in the last assumed in logic distribution. Okay, here's the results. Some general information. So doctor and nurses, their monthly income is about 2,000 yuan, which is $300 to $400 In average, doctors have 3.7 years of medical education. Nurses have 3.4. So in general, these 2 groups are generally with similar education background. All nurses are female, while there are more male than female doctors. Majority of them with permanent post. 65% of doctors and 50% of nurses have school children in their family, which we think will influence their job choices. These are some general information. So DCE results can be presented in 3 different ways. So the first way is in terms of the odds ratio. So we look at the odds ratio. The higher the odds ratio is, the more influential this factor will on the job choices. So we can say the salary monthly income of 8,000 yuan comparing to 2,000 yuan, the OR is 7. So it's a very big influence. Monthly income of 6,000 yuan, 4,000 yuan also have a very big odds ratio. The next factor is educational opportunity for children. The odds ratio is 3.4. Next one is permanent post. So from these results, I think income, educational opportunity for children, and permanent post are the top three factors will influence their choice of job choices. But additionally, all the others, all these 6 factors are statistically significant in the analysis. So this is for doctors. And for nurses, very similar pattern. The top three factors are monthly income, educational opportunity for children, and permanent post. So quite similar results. So this is the first way of presenting DC results in terms of odds ratio based on the regression analysis. The second way of presenting DC results we call willingness to pay in terms of currency. It means, for example, the working location. If you want me to work in a county hospital rather than the township health center, I would like to sacrifice 13,000 yuan. Or for permanent post, if you give me a post of non-permanent post, you'd better give me 37,000 yuan, 3,700 yuan for extra income. So that's the willingness to pay. So again, we can say this is because this comes from the same regression analysis. So the permanent post and educational opportunity for children have higher willingness. The number is higher than the other factors. So this is the second way of presenting the DC results. No significant difference between doctor and nurses, although educational opportunity, nurses 4,200, doctors 38, slightly high, but no statistical significance. So the second way of presenting it is willingness to pay. Number 3 is in terms of the percentage of doctors or nurses, they choose to remain, they have the intention to remain a rural job or choose a rural job. Here, we take the monthly income of 2,000 yuan as the baseline. So if you provide only 2,000 Chinese yuan to a doctor, there will be 64% of them choose to remain in the rural area. In other words, there will be another 35 which may have intention to leave the current job. But if we increase the monthly income from 2,000 yuan to 8,000 yuan, there's a further 27% would have the willingness to stay in the rural area. So this is I think this would be easier for the policymakers to understand rather than the regression coefficient. So again, we can say salary, children's education opportunity, and permanent post with this bar is longer than the other bars. So same regression analysis. So this is the third way of presenting DC results. And this is for the nurses, similar results. We also did some subgroup analysis. Subgroup analysis means male and female may have different preferences. People from different provinces may have different preferences. So here I won't present all the results for too many subgroup analysis. I choose 3 of them. Number 1 is the different age group. Different age group. We divide the doctor and nurses into 3 different age groups. Below 30 years old and 30 to 40, about 40. So you can say This is the monthly income, that the OR indicates monthly income. Young people, it seems young people have higher preference on the monthly income. They will have higher influence on their choice, although that may not be statistically significant. This is one. The second example of the subgroup analysis is the permanent position by different provinces. So Shanxi, this one is the west least developed area. Shandong is the eastern coastal most developed area. So it seems to me to us that in the developed area, people pay more attention to the permanent position. The reason that still remain to be understood, but this is the results. Finally, this is easy to understand, the education opportunity for children. So female have apparently higher preference on better education opportunity for their children than male. The OR is double size, 4.3 for female, 2.8 for male. So this is easy to understand. This okay. This is the results. Finally, some discussion, policy implications for future policy and research. So we identified through this DCE study that there are three top factors in rural China in the current situation, which are mostly important for their job choices, attraction and retention in health workers. Number one is the monthly income. So as I said before, the currently monthly income is extremely low in the primary healthcare in rural area, and there are also big disparity between urban and rural area, between primary healthcare and tertiary healthcare. So, but there are many barriers, of course, to increase their salary. Depends on the local government financial capacity. So we need to find, I don't know how, but we need to find some innovative way of increasing their income. So this is really the government can do to make some real changes. I believe this is to me, I think this is number one priority to do in the current situation in China. Number two is education opportunity for children. I suppose this is because of the Chinese or East Asian culture. We pay a lot of attention to the children's education. But this is not to be only addressed by the health sector. Health sector cannot set up new schools in the rural health sector. So this only need to be have to be a multi-sector collaboration to gradually reduce the gap between rural and urban area. Finally, is the permanent position in the health facilities. Permanent position usually means better social security, including health insurance and pension. So again, this is not this position is not approved by health sector. We have a Bureau of Human Resource and Social Security system, which will approve and budget the post in each health facility. Okay. And finally, in terms of method we used, we say DCE has a lot of advantages in evaluating the preference. But I would just want to mention one of the disadvantage here is the stated preference versus the revealed preference. So although we say if you pay 8,000 yuan, there will be another 27% people will remain in the rural area. But that's only what they say they will do. Whether this will predict their real choice, whether this DC result is consistent with their real job choices, is not shown in this analysis. So there may be a mismatch in the stated preference and the revealed preference. Ideal way of doing that is if you follow a cohort of medical graduates for 10 years, 20 years to see their job changes, and having this DCE and then see their job changes afterwards, to make the comparison. I thank you for your attention. That's my presentation.
Thank you. We are very interesting presentations. So now open to the floor. Questions? Any questions for Dr. Liu?
I'm very interested about the real situation about the wage gap between doctor and nurse. The current income level is only very small. The difference between these two job categories. I would like to have more information about the institutional background of why this is so in China.
I'm 40 years old now. When the mixed policy, I wasn't born then. But the situation is, I think, because of the medical education. The medical education system, I think, since the establishment of the Republic in 1949, they set up the medical education is the 3-year, 2 years medical education. So the nurses will receive the similar medical education. So if you receive same medical education, after you go into the health facility, they have similar payment level. So I think this is a historic reason for that. There's one more information I have here is we visit a lot of rural health facilities. The interesting finding is, although for the health facility to recruit either doctor or nurse is difficult, but once you recruit them into the health facility, a nurse is easier to move. So the higher mobility of nurses than the doctor. That's what we find. Possibly because of the labor market, they have more higher demand of nurses than doctors. But that's what we have observed.
I just want to add, nursing a nurse is more likely to move because, as you have seen in Dr. Liu's presentation, 99%, 7% of females. And in the Asian cultures, females, girls always could marry up. Right? So these things happened in Thailand. I remember 10 years ago, I supervised a PhD student. She comes from Thailand to look at the dentist, same as human resources. And in Thailand, they use the financial incentive to recruit the dental students in dental schools. And if your tuition fees were paid for by the Thai government, then the graduates of the dentists should work in the rural areas for at least 3 years. Okay? Then these female dentists, after 1 year, they dating with rich families, the boys from rich families, and then they get married, and then they are in-law, parents-in-law paid off their education, sort of fees. Then they left the rural settings. So that's the problem. One of the reasons the nurse and the females, they're more likely to marry the husbands in the urban areas. Then they left the rural settings. That's probably one of the factors affecting this. For the this is the educational qualification difference between rural doctors and rural nurses is not so huge. The reason is in the early stage of the founding of the People's Republic in the 50s and 60s, there was a lack of the qualified doctors working for the rural areas. So that's why there was a bear for the doctors in China. There are we call the finishing assistant like in the United States. So in order to train more medical students, they actually shortened the medical training in number of years, 2 or 3 years, and then for these, graduates with a shorter number of training years, it's difficult to find a job in the urban settings. Instead, it's easier for them to find a job, in the rural areas. That's why. Yeah. Any questions, please?
Thank you for this great presentation. I was a nursing student in China, and I'm from rural China, so I'm very happy to see this study. It's very interesting. I have a question. Would the background, like the hometown of the medical students, influence their choice of job position? Like if a student, the hometown his hometown is Shanghai, but it's rural Shanghai. And he studied in like Hubei. Would he choose to work in rural Shanghai or urban Hubei? I'm just finding
That's a
interesting.
good question. As I said in the previous, the literature shows that students with a rural background is the strong predictor of choosing a rural job after graduation. So this is I think there is strong evidence to show that. For my study, our study here, the respondents are rural doctors and nurses. So we do have a question in the questionnaire whether your background is rural, your hometown is rural or urban. Only less than 10% of them are urban cities. So we can't do the analysis whether rural and urban will have a difference in terms of job preference. But I'm pretty sure it will have a strong influence. I interviewed some students in medical university in the Western China, Ningxia, and they're not in this project. I asked them, would you go back to your hometown for graduation? What they said is, it would be a shame for their family to say, I jump up the rural family and I finally return back. That's a failure of your life, the indication of failure of your life for some of them. So they were struggle very hardly to find a job in the rural area currently. I think in the urban area. So I think the final solution is one day the gap between rural and urban will get less and less. The more and more people, or the life in the urban city getting worse and worse. People will find a job in the rural area.
Yeah, well, I'm from Finland, and from that background, I was wondering, I mean, if I understand right, your 3-year doctors, they kind of specialize. One is a surgeon and the other is an obstetrician, and so that they are not general practitioners, but they are kind of specialized. But in a Finnish context, I've been told that one of the major reasons why doctors want to go to urban areas is it because they want to have a specialized care setting. They don't want to be general practitioners. They want to do something different. And I wonder if any of that is relevant in your country. That I guess that many of the rural people go to urban areas because they have care for specialized treatments. So if you want to be a real specialist, you gonna work in an urban area because there's no facilities or no chances to be a real specialist in a rural area. So how much of that, not in your study but in the overall picture about doctors wanting to go to the urban areas, is actually a question of specialization?
In the design of this, one of the factors we have is the career development. Originally, I want to design in this area, whether you want to be a general practitioner or a specialist. But the thing is the general practitioner is now currently perceived quite differently within the professional society. So people have considered the general practitioners very differently. So, but we observe the same situation in China. When we interview the doctors in the township health and the primary health care in rural areas, all of them want to develop a specialized area. Although the national policy currently is to promote the general practice. They want national policies to want every doctor in the township health center, in the community health center, be general practitioner. But people think general practitioner is less valuable than a specialized doctor. I don't know. We think possibly for the income reasons or for the recognition reasons, but it's very really. So it's a strong phenomenon we observe. All the doctors want to be a specialized doctor. But not only if you have opportunity to move to the urban city, the tertiary hospital can develop a specialized direction. But within the township health center, they can also develop some specialized direction. For example, they can have a training for 6 months in a county hospital and a second tertiary hospital for cardiovascular disease, for example. When they come back, although they are still called GP, a general practitioner, they can mainly see patients with heart disease. So all of them are striving to develop such a direction. Yeah, thank you. Yes, please.
Thank you. That was a really interesting presentation and a great application for DCE methodology. I have 3 questions, if I could, that are kind of technical related to the DCE. One is, did I understand correctly that there were 8 different choice tasks that were given to each participant?
Yes.
Or were there 16 given?
8.
There were 8. Okay.
8 plus
All right.
1. The other one is for the consistency check.
Okay.
Yeah.
Great. And then what do you do with data when someone kind of fails the consistency check? Do you throw that data out and say this person's really not being genuine, they're not paying attention? How do you handle that?
Yeah, there's debate on literature, but currently what we did is just to throw them out, exclude them from the analysis.
And what proportion of your...
we have the 200 doctors and 160 nurses. We have 10 doctors and 3 nurses throughout of the analysis for that reason.
And then the last question, if you were to kind of hypothesize, what would you view that the actual preferences would be different from stated preferences? Do you think you predicted accurately?
No.
And if so,
No.
why not?
I met last week I was in Chicago to attending a health policy this conference. I met people from the pharmaceutical company. They said they use a lot of DCE in their pharmaceutical product. I asked the same question because in this analysis I said we can't predict whether you can use this DCE to predict the actual choice or not. But I think they can. So I asked how well you predict this. It depends. Sometimes very badly, sometimes very good. So for this DCE in drug choices. My understanding is your job choice is decided by 3 different things. Number 1 is the job preference. You prefer to work in the rural or urban. So DCE is to measure the preference. But there are other factors will influence your job choice. Number 2 is I call it compulsory regulation. So for example, if I prefer to work in an urban tertiary hospital, but I have a contract, I have to go back to my hometown to work in the rural township health center. So this will change your job preference to actual different choice. So number 2. Number 3, I think more important is the labor market situation. So although you have preference to work in the urban city, you don't have a contract and you can freely choose your job, but there's no job available in the city. There are more jobs available in the rural area. So labor market situation is also another factor. So for all these things, I think this may not predict the actual choice very correctly. Yeah.
Any questions?
Thanks for the presentation. And I have a question is that what are the main problems when the people in rural areas, when they're seeking for the medical help, what are the main problems, including the number of doctors?
You mean the problem of people seeking health care?
Mm-hmm.
Okay. For many problems, indeed. I think, to my research area, I feel in the national policy, what we said is there are 2 main problems. One is the difficult to see a doctor. The other one is difficult to afford the healthcare cost. But to my understanding, in rural healthcare, it's not that difficult to see a doctor. If you feel sick, if you have a fever, you can easily go to a village doctor or clinical township health center. But the thing is, to me, I feel, is the quality of service in the primary health care in the rural health system is really far beyond the satisfactory. So for that reason, many people in the current China, they have a better ability to pay, so they will bypass the township primary health care and go to the tertiary secondary hospital. We don't have a gatekeeping system like that in the UK. So many people go directly to the tertiary hospital in Beijing, in Shanghai. So the result is that the big hospital get very crowded. So I had a few experience introducing my friend and family relatives to see a doctor in the tertiary hospital. You have to wait for a few hours, but you only see the doctor for 5 minutes or even less for that. So that's I think that to me that's the problem of this system. One of the key reasons is the low quality of medical education of doctors in rural health facilities. Yeah. That's my interpretation of the system.
We have one more question, okay?
In this sample of the study, were the doctors all from hospitals, or did some of them come from nursing homes or other long-term care settings?
I don't do study in the long-term care system, but there are only a few of nursing home and long-term facilities in China, as I understand. So the respondent here in this study come all from the same facility called Township Health Center, which is in the rural area. They are the backbone of the rural area.
Is it like secondary hospital?
No, they are the primary, the last level. Yeah. In the city, in the urban city, we call it community health center. In the rural area, we call it Township Health Center.
Can I make a question which is not directly related to your study, but something that you said earlier on? Okay? You said about the surplus doctors in urban areas. I mean, can you tell more about how many they are? What do they do? How do they influence this scarcity? Do they advertise their services? Come to me and I'll do this and that. I mean, those who are not employed by a hospital or who are not employed by something, but they are like kind of private, doing whatever. I mean, who are they?
They are medical graduates, and they don't want to go back to their hometown in the rural area, and they can't find a job in the hospital in big cities. So we're trying to. Some of my classmates, I was trained in Shanghai in medical university. Some of my classmates, they go to the investment company, or they have a pharmaceutical company to sell drugs, pharmaceutical product. I said there's not. I didn't see national statistics. Only some. Last year in September or October, there was quite a lot of mass media coverage on the 600,000 medical graduates each year, but only 100,000 of them become doctors. So this statistics, 1/6 of them become doctors. This statistics received a lot of critics from the Ministry of Health. They said this is totally wrong statistics. We have a better statistics than that. But I don't see any probably 1/3 of them.
Alina, your question is, these people who decide, who couldn't find a job in the health facilities in urban areas, usually they don't practice medicine.
No.
They can't, or can they?
They probably in theory they can if they pass the bar, if they pass in sort of medical and get a license.
Yeah.
Okay. In theory they can, but they have to register private clinics in urban areas.
So it's not free to establish.
It's not.
No.
I don't think because the rankings, a list of settings in urban cities is very expensive in Beijing, Shanghai, so they don't have money to rent a apartment or to open up private clinics. So this is not what they are doing. What they are doing is substantial proportion of these new medical graduates, they usually work as a new professional called a medical representative. Basically, is working for big pharmaceutical industrial. So they are the medical representative for the pharma companies, promoting the new drugs. For example, GSK. in China hired lots of people promoting their products. So they went to the hospital to talk to doctors. They use their connection, their former classmates to sell all these So this is of the one of the choices they have got. Second is they just give up their medical profession at all. They, as Xiaoyun mentioned, they could work in the joint ventures because they are English good probably. They know they are well educated, so they act as secretaries for the joint ventures, big companies, earn more money. Or they work on change the profession slightly. For example, they could work as a biostatistician, do the data analysis for farmers or for other biomedicine in the companies.
What would happen if they just establish a practice in their home and start treating patients? Would they be punished?
They can go back to their hometown, open clinics,
But in a big city, can they open?
Basic is their investment cost. Property price in big cities is so expensive, and these are new middle class. Without their family support, they cannot rent a proper, promise to open the private clinics. In theory, yes, but in practice, no. Okay, last question.
I have a question about the sampling. Your sampling population is the primary health, the doctors in primary health centers, and that what will be the result if you conducted the same study in some high quality universities such as the Peking University Health Center? Will the result will be different? Since I think most students with 8-year medical education from those good medical schools might have a different choices when they find a job. Is there any differences?
There will be big differences, I think. Some of my students, they did on one of my teaching courses, they did a very pilot survey within the Peking University Health Center to see the preference of the medical student there in the hospital. Almost none of them would like to choose a rural job. Like they don't use this PCE, but they just to say using a cross-sectional survey whether you would like to choose a rural job after graduation. None of them would like to. So, and the thing is, I think some universities like Fudan, Peking University, I think the objective of their medical education is not to train rural doctors. So you can't expect them to work in the rural area. I think there are, for the primary health care doctors, there are certain medical universities like provincial level or prefecture level medical university. I think their vision, their mission is to to train doctors for the primary health care in the rural area. So I think the medical university can have different task and responsibility to do.
Okay, thank you. I think this recruiting and retention the doctors in the rural areas, particularly remote areas, is the global challenge. So the implications for both developed and developed countries. Every country, I guess, from Australia to China to Africa, is facing the same challenges. So today's seminars, I think, is very interesting and policy relevant. So let's thank you, Dr. Liu, again.